Hello, my name is Chiyoyokose, and in this section, I'll be providing an overview of the management of acute gout flares. So you may recall the stages of gout diagram from one of my previous lectures. And for this section, we'll be focusing on addressing the acute crystal-induced inflammation that's associated with recurrent gout flares. So a couple of points before we talk about the specific medications. You may recall I mentioned previously, anti-inflammatory medications are the mainstay of therapy for the management of acute gout flares. No matter what specific medication is chosen, they're all most effective when taken at the first sign of a gout flare. And for this reason, we often take a pill-in-pocket approach. This refers to where patients are given a supply of their gout flare treatment medications to have on hand at all times, so that at the first sign of a gout flare, they can start taking the medication, even if it's in the middle of the night or over the weekend. So there are three main drugs or categories of drugs that we use to treat acute gout flares. And the first one that we'll be talking about is colchicine. So colchicine is an anti-inflammatory agent that reduces monosodium urate crystal-induced activation of the inflammasome and neutrophil endothelial adhesion. It's usually the first-line flare medication for most patients with gout, and it is the preferred medication for this trial. There's a loading dose associated with colchicine, so patients are instructed to take 1.2 milligrams at the first sign of a gout flare, followed by 0.6 milligrams 1 hour later, for a total of 1.8 milligrams of colchicine during the first 24 hours. Then they're advised to continue 0.6 milligrams twice daily of colchicine until the resolution of their flare symptoms. In general, it has a very favorable safety profile if dosed appropriately with close monitoring, even in patients with mild renal insufficiency or those with CKD stage 3A in this trial. So this is the table that depicts the colchicine dosing. So on day 1, again, it's a loading dose. Take 2 tabs or 1.2 milligrams at the first sign of flare, followed by another tablet or 0.6 milligrams 1 hour later. And then on days 2 through 7, patients are instructed to take 1 tab twice daily. Some treatment considerations to keep in mind. The most common and earliest side effects to appear usually relate to GI discomfort and may include things like abdominal pain, cramping, and/or diarrhea. It is possible to experience more rare but serious side effects such as neurologic or muscle-related toxicity. However, it's exceedingly rare if the colchicine use is monitored and if the medication is stopped or dose reduced at the first sign of toxicity, which again are usually GI. There is an increased risk of adverse events among patients with renal insufficiency or concurrent use of other medications that may affect colchicine metabolism by inhibiting the CYP3A4 or P-glycoprotein enzyme systems, which relate to drug metabolism. Examples of such medications include clarithromycin and antiretroviral agents for things like HIV, which have a strong interaction, and medications such as diltiazem or verapamil are reported to have a moderate interaction. Moving on to the second category of drugs, or NSAIDs. So all NSAIDs, or non-steroidal anti-inflammatory drugs, are considered to be equally effective for the treatment of acute gout flares if used at their maximal anti-inflammatory doses. So in this trial, the NSAID of choice is naproxen, dosed 500 milligrams twice daily. Naproxen can be used in subjects with normal renal function or up to stage 2 CKD, meaning GFR of greater than or equal to 60. However, it should be avoided, and alternative therapy should be considered in subjects with stage 3A CKD or eGFR ranging from 45 to 59. This is the dosing table for naproxen. There is no loading dose associated with it. So on days 1 through 7, subjects are instructed to take 500 milligrams twice daily with food to protect their stomachs. Some treatment considerations for naproxen. As I mentioned, there is a GI risk associated with naproxen related to the development of gastritis or peptic ulcer disease. And so in addition to taking it with food, often we consider adding a proton pump inhibitor or PPI or other acid suppressant medications for GI protection, particularly among those on aspirin. Naproxen can also promote hypertension and fluid retention. So you may want to consider alternative therapies in subjects with poorly controlled hypertension or heart failure. It can cause an acute kidney injury. Therefore, it is recommended to avoid in subjects with CKD stage 3A, as I mentioned in the slide prior. It can increase one's risk of bleeding, and it can be associated with an increased cardiovascular event risk. And so often we also consider alternative therapies in subjects with a very strong cardiovascular disease history or risk factors. And the last class of medications are steroids or corticosteroids. They're basically synonymous. And the steroid of choice in this trial is prednisone. It's usually started at a relatively high dose and tapered over the course of days to weeks. And steroids can be used in subjects with renal insufficiency with no dose reduction and no increase in the risk of side effects. So this is the dosing table for prednisone. As you can see, patients are instructed to take a higher dose of 40 milligrams per day for the first 2 days. All pills should be taken all at once. And every 2 days, they lower the dose of prednisone by 10 milligrams, so a total of 8 days of treatment. Some treatment considerations for prednisone: there can be some psychiatric side effects. It can cause anxiety or mood and sleep disturbances. Specifically for the sleep issue, it's usually recommended to take it in the morning so that it doesn't interfere with their sleep as much. Prednisone can also raise blood sugars, and so it should be used with caution in subjects with diabetes. In rare cases, their diabetes medications may need to be adjusted. For example, their insulin requirements may go up while on the prednisone, even with short-term use. Similar to naproxen, it can raise blood pressure and cause fluid retention, and so it should be used with caution in subjects with heart failure in particular. It also has GI side effects, or it may have GI side effects. It may contribute to peptic ulcer disease, particularly among those also on NSAIDs. And it is technically considered an immunosuppressive medication, meaning it can increase one's risk of infection. However, this is really an issue with long-term prednisone use, and so should not become a major issue with the short-term use in the case of the management of acute gout flares. So this concludes this section. If you have any further questions, please refer to your educational materials or talk to your PIs. Thank you.